Hepatitis A is inflammation of the liver caused by infection with a hepatitis virus. Hepatitis virus is a non-enveloped single-stranded RNA virus which is classified in the hepatovirus genus of the Picornaviridae family. The virus replicates in hepatocytes, liver cells, interfering with cell function and causing inflammation of the liver. Hepatitis A is usually a self-limiting illness with a good prognosis. It typically has 4 clinical phases: incubation, prodromal, icteric, and convalescent. In adults, 70–95% of infections result in clinical illness. In children younger than 5 years of age, 80–95% of infections are asymptomatic. Public Health England uses the following case definitions for hepatitis A. Clinical case, possible. A person with an acute illness, discrete onset of symptoms, and jaundice or elevated serum aminotransferase levels. Probable case, meets the clinical case definition above, and has an epidemiological link to a confirmed hepatitis A case. Or meets the clinical case definition and has IgM antibody to the hepatitis A virus, anti-have IgM. Confirmed case, meets the clinical case definition and has IgM and IgG antibodies to hepatitis A, or has hepatitis A RNA, have RNA, detected regardless of clinical features, or is asymptomatic with no recent history of immunization, but has anti-HAV IgM in oral fluid or serum, and has an epidemiological link to a confirmed hepatitis A case. Transmission of hepatitis A is by the fecal-oral route. The mean incubation period is 28 to 30 days, with a range of 15 to 50 days. In countries where hepatitis A is highly endemic, it is mainly transmitted by close personal contact or via feces, contaminated food, and water. In countries where hepatitis A is uncommon, new infections occur via travel to places where the virus is highly endemic. People who have acquired the infection abroad may then transmit the virus to others upon their return. Small outbreaks can occur among unvaccinated children or adult contacts and are often seen in men who have sex with men and injecting drug users, risk of fecal contamination of drug-injecting equipment. Hepatitis A virus is excreted in bile and shed in the faces of infected people. K excretion of virus occurs in the 2 weeks prior to the development of jaundice, and then drops but can persist for more than 40 days after jaundice onset. Shedding may continue for longest in infected infants and children. Virus RNA has been detected in the faces of newborn babies for as long as 6 months after infection, in people who are immunocompromised, and in those with HIV infection. Vertical transmission of hepatitis A from mother to child is very rare. Isolated case reports. People at high risk of hepatitis A infection include travelers to areas with a high prevalence, people with clotting factor disorders, factor V8, and factor IX concentrates have been identified as rare sources of hepatitis A infection, men who have sex with men, and people with risky sexual behaviors, sexual practices involving oral, anal, or digital rectal contact, those who have multiple sexual partners, anonymous partners, sex in public places, and group sex. Injecting drug users and their close contacts at risk of poor standards of personal hygiene, with possible fecal contamination of shared drug equipment and other paraphernalia. People at occupational risk, such as laboratory workers, staff of large residential institutions, sewage workers, and people who work with primates. The most important determinant of illness severity is age, and there is a direct correlation between increasing age and morbidity and mortality. Most deaths from acute HIV infection occur in those over the age of 50 years, even though infection is uncommon in this age group. Prognosis. Around 85% of people with hepatitis A infection make a complete recovery within 3 months. Almost all people with hepatitis A recover fully within 6 months. Hepatitis A has no long-term sequelae. It does not cause chronic liver disease, has no chronic carrier state, and results in lifelong immunity. Complications. Cholestatic hepatitis. This can occur in around 8% of people. Features may include severe pruritus, diarrhea, weight loss, and malabsorption. However, they usually fully recover. In around 15% of infected symptomatic people, fever, pruritus, diarrhea, jaundice, weight loss, and malabsorption can exhibit a relapsing course persisting for several months. Fulminant liver failure occurs in around 0.4% of people and can lead to coagulopathy and hepatic encephalopathy. It usually manifests during the first 4 weeks of illness and is more common in people with concurrent chronic liver disease, including chronic hepatitis B or C infection. It has a mortality rate of 40% without liver transplantation. Other rare to very rare complications include calculous cholecystitis, pancreatitis, aplastic anemia, autoimmune hemolysis, autoimmune thrombocytopenic purpura, hemolysis, G6PD deficiency, Guillain-Barré syndrome, mononeuritis multiplex, post-viral encephalitis, transverse myelitis, acute renal failure, cutaneous vasculitis, cryoglobulinemia, and reactive arthritis. Overall, hepatitis A infection has an estimated mortality rate of 0.1% for children younger than 15 years of age, 0.3% for people 15 to 39 years of age, and 2.1% for adults 40 years of age or older. Symptomatic hepatitis, severe disease, and death are more likely to occur when infection occurs at an older age. Note: most children and up to half of adults are asymptomatic or have mild nonspecific symptoms with little or no jaundice. The clinical features of acute hepatitis A are common to all forms of acute viral hepatitis, and it cannot easily be distinguished by history, examination, or by routine biochemistry tests. Suspicion may be increased, however, by a history of a specific exposure or risk factor. The clinical features of the prodromal phase of hepatitis usually last 3-10 days, include flu-like symptoms such as general fatigue, malaise, joint and muscle pain, low-grade fever up to 39ec, gastrointestinal symptoms such as anorexia, nausea, vomiting, and right upper quadrant abdominal discomfort. There may be accompanying headache, cough, sore throat, constipation, diarrhea, itch, or urticaria. Usually there are no specific signs on examination. The clinical features of the icteric phase of hepatitis usually last 1-3 weeks, but can persist for more than 12 weeks, include jaundice, pale stools and dark urine if cholestasis, pruritus, present in 40% of those with jaundice, fatigue, anorexia, nausea, and vomiting. Symptoms often improve once jaundice occurs. Hepatomegaly, 85%, splenomegaly, 15%, lymphadenopathy, 5%, and hepatic tenderness are often present on examination. The clinical features of the convalescent phase of hepatitis may take up to 6 months, include malaise, anorexia, muscle weakness, and hepatic tenderness. Investigations: specific antibody tests. IgM antibody to have is positive with onset of symptoms, usually about 3 to 4 weeks after exposure, but up to 6 weeks. The test is sensitive and specific. It remains positive for between 3 to 6 months, up to 12 months. It remains positive in relapsing hepatitis. IgG antibody to have appears soon after IgM and persists for many years. In the absence of IgM, it indicates past infection or vaccination rather than acute infection. IgG remains detectable for life. Liver enzymes. Alanine aminotransferase ALT rises more than aspartate aminotransferase AST, again with onset of symptoms, about 4 weeks after exposure. Levels usually return to reference ranges over several weeks, but can remain elevated for months. Hepatitis serology. The most sensitive test for diagnosing acute hepatitis A infection is a PCR test for hepatitis A RNA. However, this test is not widely available. In the absence of routine RNA testing, detection of hepatitis A virus, immunoglobulin M, HBeAg-M, and hepatitis A virus immunoglobulin G, HBeAg, should both ideally be conducted to strengthen diagnostic accuracy. Have IgM antibodies are detectable from at least 5 days after the onset of symptoms, peak during the acute or early convalescent phase of the disease, and usually remain positive for 45-60 days but can persist for around 6 months. HAVIG antibodies are detectable 5-10 days after the onset of symptoms and then persist. Many laboratories use a total antibody assay instead of a pure IgG assay to check immune status. If serology shows positive HAV-IgM and positive HAVIG, acute hepatitis A infection is likely. A high IgG reactivity and a moderate level of IgM suggest hepatitis A infection in the recent past rather than current acute infection. Positive HAV-IgM and negative HAVIG IgM result may be a false positive. Negative HAV-IgM and positive HAVIG suggest past hepatitis A infection or immunity from previous vaccination. Serology results should be interpreted in the broader context of timing of illness onset. If serology is taken in the first 7-10 days of symptoms, there is a small risk of a false negative result, so serology should be repeated 1-2 weeks later. The age of the person, false IgM results are more likely in older people, a group likely to have had hepatitis A in childhood. Comorbidities. HAV IgM serology may not be reliable in patients who are significantly immunocompromised. Risk factors for hepatitis A. Results of liver function tests. Liver function tests. Alanine aminotransferase ALT and aspartate aminotransferase AST levels may be significantly increased, usually between 500 and 10,000. Bilirubin may be elevated, usually between 85.5 and 171, but can reach up to 500. Levels may be very high and remain elevated for several months. Older patients have higher bilirubin levels. Alkaline phosphatase is generally less than 2 times the upper limit of normal, but higher if there is cholestasis. Prothrombin time may be prolonged. 5 seconds or more suggests severe hepatitis, and 50 seconds or more suggests acute liver failure. PT usually remains normal, and estimation is necessary only in unusual cases or with complications. PT prolongation by more than 5 times is a sign of severe infection. Other tests. Mild lymphocytosis is common. Pure red cell aplasia and pancytopenia may very rarely occur. Ultrasound may, rarely, be needed to exclude other diseases. The differential diagnoses of hepatitis A include viral hepatitis caused by other viruses, such as hepatitis B, C, D, and E, Epstein-Barr virus, infectious mononucleosis, or cytomegalovirus, CMV, alcohol-induced hepatitis. Suspect if there is a history of alcohol misuse. Drug-induced liver disease. Suspect if there is a history of paracetamol overdose or therapeutic use of paracetamol in a person who misuses alcohol. Acute HIV infection. Autoimmune hepatitis. 90% of cases occur in women. Suspicion is raised by presence of other autoimmune disorders. Hepatitis caused by bacteria such as leptospirosis and Coxiella burnetii. Granulomatous disorders. Wilson's disease. Prevention of infection with hepatitis A. Vaccination is indicated for people considered to be at high risk of acquiring hepatitis A infection and/or those at the highest risk of complications, including people traveling to or going to reside in areas of high or intermediate prevalence. Vaccines should preferably be given at least 2 weeks before departure, but may still provide some protection when given up to the day of departure. People with chronic liver disease, including hepatitis B or C infection. Risk of complications is increased. People receiving plasma-derived clotting factors to treat hemophilia. Injecting drug users. Men who have sex with men with multiple sexual partners. People at occupational risk. People at occupational risk. People from higher endemic areas. Consider pre-vaccination serology testing for hepatitis A virus immunoglobulin G, HAVIG, to check for immunity in people from highly endemic areas, those with a prior history of hepatitis or jaundice, and in men who have sex with men. If immunity to hepatitis A is demonstrated following initial serology testing, there is no need to vaccinate the person. For all other people at high risk, who are not known to be immune, offer hepatitis A vaccination. The usual schedule for monovalent hepatitis A vaccines is a single dose, and then a booster dose 6 to 12 months later, if the person remains at long-term risk of contracting hepatitis A. Some vaccines combine hepatitis A with other antigens, typhoid or hepatitis B, and may require different schedules. Pregnancy is not a contraindication to receiving the hepatitis A vaccine where clinically indicated. Note: combined hepatitis A and B vaccines should be considered for people at risk of both infections. Advice: in order to avoid hepatitis A infection, advise people to practice safe sex to reduce the risk of sexual acquisition transmission, avoid reusing, sharing, injecting equipment, thoroughly wash their hands before food preparation and eating, ensure good personal hygiene, traveling to moderately or highly endemic areas to avoid food and water potentially contaminated by human faces, in particular, foods grown close to the ground, such as strawberries and salad vegetables, and undercooked or raw mollusks that feed by filtering large volumes of sewage-polluted waters, such as mussels, oysters, and clams. Use appropriate protective gloves, boots, and face protection, as required within their occupational role. Management of hepatitis A is mainly supportive with treatment of symptoms, fluids, antiemetics, rest. Avoid alcohol until liver enzymes are normal. Admit patients with severe systemic upset or intractable vomiting for rehydration and observation. Pregnant women should be advised of the increased risk of miscarriage and premature labor, and the need to seek medical advice if symptoms develop. Employment history should be obtained so the patient can be advised appropriately. Until patients become non-infectious, they should be advised to avoid food handling and unprotected sexual intercourse. Advice on managing any outbreaks should be sought from UK regional public health organizations. Admit any person with hepatitis A infection to hospital if they are severely unwell. Advise the person to seek medical attention if symptoms worsen, particularly if they include vomiting and dehydration, and to be aware of the signs of hepatic decompensation, change in personality, or level of consciousness. If hospital admission is not required, provide supportive symptomatic care as required. Advise the person to rest when necessary and stay hydrated. If pain relief is required, options include paracetamol. Normal dosages can be used unless there is evidence of moderate or severe liver impairment. If serum bilirubin is greater than 300 or prothrombin time is greater than 3 seconds, reduce the dosage to a maximum of 1 gram 2 or 3 times a day. Ibuprofen, a weak opioid such as codeine, if liver impairment is mild. Avoid codeine in severe liver impairment, enhance sedative effects, and reduce drug clearance. If treatment of nausea is required, options include prescribing metoclopramide, maximum duration of treatment 5 days, or cyclizine at normal dosages if liver impairment is mild. Seeking specialist advice on the choice and dosage of antiemetic if the person has more severe liver impairment. If treatment of itch is required, options include simple measures such as maintaining a cool, well-ventilated environment, wearing loose clothing, and avoiding hot baths or showers. Chlorpheniramine at normal dosage at night, avoid in severe liver impairment. The dosage can be increased to every 4-6 hours if itch is severe. Ursodeoxycholic acid, cholestyramine, and corticosteroids. Seek specialist advice before prescribing. Notify the Health Protection Unit, HPU, promptly to facilitate appropriate surveillance and contact tracing. If an outbreak is suspected or the person is a food handler, notify the HPU immediately. Provide the person with information and advice about hepatitis A. In particular, advise them to avoid drinking alcohol during the acute illness, as this can increase the risk of liver damage. Avoid work, school, or nursery until they are no longer infectious, typically 7 days after the onset of jaundice or 7 days after the onset of symptoms. If there is no history of jaundice, take steps to minimize the risk of transmission to partners and contacts. The person and all close contacts should ensure thorough hand washing after using the toilet, including supervising young children who may have difficulty with personal hygiene. Wash their hands immediately after changing nappies or helping with child toileting, including handling a potty. Ensure good general personal hygiene. Avoid handling food if possible or thorough hand washing before food preparation for contacts of cases. Avoid unprotected sexual intercourse, including oroanal and orogenital contact, until the person is no longer infectious, typically 7 days after the onset of jaundice, or 7 days after the onset of symptoms if there is no history of jaundice. Avoid sharing needles and other drug paraphernalia. Advise pregnant women with acute hepatitis A infection that they may be at increased risk of preterm labor if infection occurs in the second or third trimester. Infection in early pregnancy is not thought to increase the risk of congenital malformation in the infant. Breastfeeding is not known to pose a specific risk. Providing thorough hand washing and personal hygiene is maintained. Consider referring the person to a genitourinary medicine department or other specialist sexual health service if screening for sexually transmitted infections is appropriate, and/or drug rehabilitation agency, if appropriate. Follow up at least every 1 to 2 weeks. Consider more frequent follow-up if the person is symptomatic and/or has jaundice, and depending on the results of liver function tests. Repeat liver function tests until aminotransferase levels are normal, usually 4 to 12 weeks. Seek specialist advice if the person has significantly abnormal liver function tests, for example, aspartate aminotransferase AST or alanine aminotransferase ALT levels greater than 2000, bilirubin greater than 300, or prothrombin time greater than 3 seconds, or if liver function appears to be worsening. Contact with hepatitis A. Management of people who have been in contact with someone with hepatitis A. If a person presents who has been in contact with someone with known hepatitis A infection, contact the local health protection unit, HPUA, immediately, who will advise on further management if the person has not previously received hepatitis A vaccine. This may include giving hepatitis A vaccination and/or arranging for the administration of human normal immunoglobulin, depending on the timing and circumstances of contact, as well as other factors including the person's age and comorbidities.